Morning. Welcome to our third day of 6th International Keloid Symposium here in Amsterdam. And we are going to start the session on pediatric keloids. I have here with me Professor Dan Deng from Shanghai, a great friend, our co-host in last year's conference. She is a leader in pediatric dermatology, dermatological surgery in Shanghai and known internationally. And I would like her to present to us what she has to say this morning.
Good morning, everyone. Dear friends, I'm so happy to be here. Now it's the third day. Yeah, actually the last day for our conference. Very happy. And yesterday, because the day before yesterday I was not here, but the whole day yesterday we had very, very good presentations and a lot of discussions. That's very precious. I think this morning, and we're going to have the first session, and we're going to welcome our chairman, Dr. Michael Tirgan, to have the first topic. The presentation will be Challenge in Pediatric Keloids. Let's welcome. Thank you.
Thank you so much, Dan. Thank you very much. Thank you for your kind words. Thank you. So as I presented to you the first day and the opening, there are lots of challenges that we deal with in managing keloid patients. Pediatric keloids are in particular more challenging. And I'm going to share with you an email that I received fairly recently, and you can see the stress in this email. It comes from a mother of a child the child is 5 years old. Sincerely hope that this finds you well. Our little boy has developed a keloid in his neck. He had surgery September 7, 2022. Keloid started around December, January 23. Surgeon thought it was hypertrophic scar. We were doing silicone gel at that time. So this child had a neck surgery. Just show you what it was so you get an idea. And Keloid started in May of 2023, received 3 doses until September with no response. He, however, now has a significant area of hypopigmentation in the neck, way beyond the keloid. Please assist. I mean, when the email ends with this, please assist, it shows you how desperate, and this comes at 10 p.m. So, this little boy has this little thing in his neck, and it's basically changing the life of the family. He had a cyst in his neck, had underwent surgery, and we can see the loss of pigmentation around here. This is the point I have made about using high-dose steroids. This kid did not see any benefit from it and has developed hypopigmentation in his neck. Linear relationship to side effects and not to efficacy. So the parents, we initially thought that we would start this with cryotherapy and try to freeze it, because when you deal with a kid that's 5 years old, you have to think of things you don't want to be doing and things you may want to do. What are the things that you don't want to do to this? Is anybody going to remove this surgically? This kid just had surgery and developed this. So you do another surgery, it's going to come back, no doubt. Are we going to do surgery followed by radiation on a 5-year-old in his neck area near his thyroid at an age that is a very early age? Perhaps not. I wouldn't. Some of us, John maybe, but I wouldn't. So you need to think safety. So what are the safe things we could do? Steroids have been used, so we're not going to be using steroids again, correct? So what are we left with? Cryotherapy is one. Intralesional chemotherapy next. Anybody has any suggestions as to how you would be dealing with this in this patient? 5-year-old who just had surgery and developed this and has not responded to steroid injections. How would you manage this? Anyone? Frank? Oh, yeah, microphone. Sorry. I'd love to hear your thoughts. Okay. All right. So, Frank, tell us how you would manage this 5-year-old.
Yeah, that's always difficult, especially when they've been elsewhere. What you see is that the corticosteroids were not applied very well. They were applied probably below the scar instead of inside the scar. So if I see a patient like this, I first do another corticosteroid injection on the way I do it to have a look first. Is it a non-responder or not? Is it really true that it's not a non-responder? And we put like amla cream, lidocaine cream before, and then do my injection very superficially. That's what I do first. And if that's not working, then I do the freezing, yes, combined with superficial corticosteroids if necessary.
Okay. Thank you. Anybody else? Sarge? And
Yes, thank you. If it's me, if the child comes for me, to me, I will definitely first to choose the injection, and because this is enough. If not, the taxone, and also we can add the Plamson, something like that. So chemo, I think
you would
enough.
consider chemo injection.
Yeah.
Good morning to everybody. Yeah. So I will do excision, and I will give Keloid injection. The reason being, he is resistant to Keloid, but we don't know what patient actually means, and we don't know what technique the previous doctor has given. So this is a child, and let him not, even when we give any injections, it is just gonna become flat, and it is still gonna look the scar. So it's not gonna be a great for the kid, where there'll be peer pressure when he goes to school. They'll say something is stuck in your neck, something is stuck in your neck. So what I prefer is, if the child comes to me, I will excise that completely and give a nice thin line scar. And at the time of suturing, I will give him injection triam into the dermis, and I will close the stitch. Then at the time of suture removal, maybe I will give a smaller dose. Instead of 0.1, I'll give 0.05 mg into the scar area. And then I'll call the child once in 6 weeks, I'll observe. Maybe I'll repeat after 6 weeks. I'll give 3 sittings of injection triam. Then I will give the scar massaging gel to the parents. We use cicatrix gel back home, and that has a factor which suppresses transforming growth factor beta. So it actually works well. So I'll teach the parents how to do the massage. So the massage technique is, we put the gel ... over the scar, and then we massage 20 times front, 20 times back. So by this, the fact is, it opens the pore. Then after that massage, again, we'll take the gel and apply over the scar. So open pores will take the gel inside. And I will also educate the parents on putting silicone gel sheet at night to avoid recurrence and to avoid further surgery. So I'll follow the kid for some time. I think this is how I'll manage. The reason why I'm suggesting this is, back home, we have small girls, the teen girls, who want to wear earrings, and they have keloids in the ear lobules. So this is how we manage. We excise the keloids. We make sure they're in follow for 3 to 4 years, and this is the routine we give.
I appreciate that. What would you do if after all of this would recur?
The chances of recurrence?
No, if it recurs, forget about the chances. The patient comes back to you 6 months later the same way. What would you do then?
Maybe I'll...
That's a challenge.
Yeah, that's definitely a challenge. When there is a recurrence, yeah, maybe I will not go for surgery. I'll just go with the triam injection. And I will also advise parents, during my first treatment itself, the chances of recurrence is very high if you're not going to do the massage or follow-up. If they fail that, then they have come with a failure, they have not followed the doctor's instruction, then I will tell them, this time I'm not going to do surgery because we have already done the extensive procedure. Rather, I will give first the Triam injection, the steroid injection, and I'll see how it works. Because the technique what I give is different from the doctor's previously he took. So I will try that first, and if it doesn't work, then I will go for a combination of Triam with 5FU together.
Okay, thank you.
I think first, wait to do an operation, because this is a small child and he's not bothering at that time, maybe itch, but that you can handle with an injection. And if you want to do an operation, do it later on when the child indeed is bullied with it. That's the one thing. And the other thing, if I would do an operation, I first would make the scar as flat as possible, because if there's still inflammatory reaction inside the scar, you have a higher chance of recurrence, which is bigger. So you have to flatten it completely, and then if that's possible, then you can do, if you want to, an operation. But I would not do it immediately and want to have the scar as less inflamed as possible before operation.
One more comment and question, and then I want to move on.
Yeah,
to this.
it's just one suggestion, bearing in mind it's a 5-year-old. In the UK, we have a steroid-impregnated tape, and I entirely share the view that the steroid injection depot has actually diffused, probably because the keloid is so dense and the injector hasn't been able to get it actually in the substance. This is one of the instances I would actually use the fludroxycortide tape that we have, which can be cut to shape and applied for 12 hours. So it releases over 12 hours. And then for the other 12 hours, do some duoderms or some other silicone-based dressing, compression, and really see how much I can soften it. I really think one would start as non-invasively as possible with a small child like this. That's my comment. Thank you.
The reason why I chose surgery at the first place is, with all the injections, what is happening is the keloid, what we see as a thin line, it is expanding. This keloid is formed by pulling the normal healthy tissues. So it looks contracted and bulged up. After we give injection, when the scar becomes flat, the scar widens. It becomes 2 to 3 times more than compared to what it was in the beginning. So it's going to be whatever raised line is going to become a rectangular flat scar.
I have several cases to share. If you allow me to proceed with the other cases. Sure.
When I read that letter, I felt desperation that I felt when she was 3. And we saw a pediatric surgeon, and he said, don't cut. And he said, press, keep putting pressure. And we kept putting pressure. And it got down. But what he didn't tell us is that we're part of the solution, that we, the parents, are part of the solution, that we have to be part of it, because there are parts of it that we have to do. We have to watch it. And I think when doctors are working with parents as desperate as us, you have to let us know you don't have the answer, and that we're on this journey with you to discover what it is. And I think that's the most humble thing a doctor can do, because we see a doctor and he acts in a particular way and we think he has the answer, and we walk away thinking that's the answer. 3 months later, 6 months later, it grows. You go to the doctor, he's fed up. There's nothing else I can do. So I like this question that Dr. Tirgan has asked. But please remember that keloid is not just the doctor's work. How do you explain to the patient or to the patient's parents? Omi was 2 when we started working on it. She's in her 40s. We're still on it. And so it's important for doctors to recognize this, that you're on a journey with us, for us to measure the keloid, for us to watch it, and for us to find the kind of expert that we need to use. Thank you.
Thank you very much. That's quite insightful coming from a mother dealing with this in her child. I have several cases to share with you. Let me just quickly go through this. So we felt that perhaps the safest, I didn't want to repeat the steroid injections. At first, didn't want to move into chemotherapy of concerns of the parents. So we started with cryotherapy. And you can imagine how difficult it is to cryo. This is painful. You need to numb this. The patient is not going to sit. Surgery would be done under general anesthesia. You cannot perform surgery as outpatient as you would do in an adult. So in using local anesthetic, I also infiltrated the keloid tissue with steroids and froze it. So this child comes back about a month later. There is some improvement, but there's not much improvement to talk about. Still, the process still there, slightly better. So then we decided to proceed with intralesional 5-FU. So I treated this 3 times with intralesional 5-FU, and we started seeing improvement. And as you can see, I use extremely low doses of these drugs mixed with triamcinolone. The hypopigmentation has improved already in a matter of few months by not injecting any more steroids in this. And despite 5-FU, there was some remnant. So I escalated through the same procedures of chemotherapy that I mentioned to you. This is August 24, October 24. The much better slight presence of the tissue there. October 10th, 25. So we moved 1 year past. This is completely flattened. There is area of hyperpigmentation here. Hopefully over time this would resolve and the keloid process has significant, that actually is not present there anymore. So this is how I proceeded with this one patient. You can do whatever you think is most appropriate for your patients when you encounter these patients. This is another 6-year-old who presented. She was pierced at age of 9 months and developed bilateral posterior earlobe keloids. At the age of 3, a plastic surgeon took her to surgery. Under general anesthesia, removed both keloids posteriorly, and also I read the operating report. We reported this first as this patient who had developed her first kid at the age of 9 months. This kid developed it at the age of 9 months. This is the youngest reported. So he cored through the earlobe. And then later on, this kid developed a keloid in anterior aspect of her earlobe where she had nothing before. The keloid was posterior to the earlobe. Now post-op is there. So I treated this with cryotherapy, the same method that I had shown you before. And this is her past history, basically. And we published it. This is bilateral. So in this kid, our goal was to treat this keloid and prevent any of this. And prevention would have started with not doing that surgery to begin with. Because that surgeon, my opinion, with all due respect, put this patient through this path. This is a path that would move towards this very large keloids. It would move towards loss of earlobe. And later on, this kid, this is 2022, several years later, the keloid, her earlobe is actually in a decent shape. There's no more keloid there. There is some discoloration and scarring there, but there's no active keloid there. 6-year-old who was bitten by a family dog 15 months earlier has a multiple steroid injections, a steroid tape, and creams, came in March 22. Again, I don't want to ask this from audience, but briefly, can one of you tell me how would you manage this? Besides surgery, I hear you take this patient to surgery. I know that already. Anybody would do something different? Anybody would do something different than surgery? So I'm not a surgeon, so obviously this patient was under my care. I didn't do surgery. So I decided to use cryotherapy to debulk. Remember the protocol I provided to you, debulking with cryotherapy followed by intralesional chemo. It worked. This got better. And here she got 1 dose of 5-FU. Later on came back with minimal keloid there, put her on that cream combo that I told her. Ever since, this has been flat and has not recurred. This is a 13-year-old patient. I don't know if Dr. Cooney is on Zoom with us or not right now. Dr. Cooney, my great friend from Johns Hopkins in Baltimore, referred this patient to me. This child, his history is quite interesting. He was 13-year-old at the time. He was struggling with keloids in his pubic area after some reconstructive surgery for 9 years. This was triggered by that. And his prior treatments are basically listed here. It's interesting to read through some of this history. He started having keloids at age of 4, underwent Keloid injection, cortisone injection, separate occasion with no benefit, underwent multiple excisions, not one excision, Dr. Prima, multiple excisions, and keloids followed by Keloid injection. However, they still recurred. He received CO2 fractionated laser 2019 laser treatment intended to shrink the keloids. However, his mom expresses that it only made it worse. Remember we talked about laser treatment making keloids worse, and some of you questioned this. Here we know what kind of laser it was used at Hopkins, one of the best centers in US. It has nothing to do with the laser. It has nothing to do with the method of laser. It has nothing to do with who the operator is. This is one of the best centers in US. It's the nature of the keloid disorder that can get worse with laser, no matter who does it. And they basically started injecting this with intralesional 5-FU, and they didn't see much response, and the mother is seeking. His mother has a history of keloids and reports having aggression to 5-FU, the mother herself. So kid underwent 3 5-FU injection to these masses on these dates. Mother doesn't feel the injections have been effective. They're hoping to transition to a different treatment. What different treatment would they transition to? Anyone. So I asked one person to suggest. You read the history, you heard the history. Multiple excisions, not one. Multiple Keloid injections, multiple 5-FU injections, worsening with lasers. Somebody tell me, what would you do with this patient? Cryo. What else? Cryo. So, and you can imagine that treating this patient is difficult. You need to convince the family, you need to convince the mother, you need to spend time with them to educate them. And cryo is going to be painful. This is a 13-year-old. You need to be extremely cautious. So with this patient, we started to test cryo in only one area to see how he would do. We just froze this corner. The laser pointer is not here. We froze a corner of the keloid on the left side. I wanted the patient to see how it feels. This was done under local anesthetic. Patient tolerated the local anesthetic injections. He was 13. And the family needs to learn how to deal with aftermath of cryotherapy. Patient needs to learn with that. And they came back and they saw significant improvement of that area that was removed. So we did more cryo, and the rest of that side came off. This is later on. Then we continued with cryo on the opposite side, and we were able to remove and debulk all of that. The patient took a break, September 2021, came back March 22, 6 months. There was minor recurrences. These were treated with repeat cryo and followed by intralesional 5-FU twice. And this is the subsequent, September 2022. This patient has been in remission since. So assume this method of treatment was applied 9 years earlier. It would have been perhaps more successful, and the kid have not been put through numerous surgeries, numerous procedures, numerous visits to the hospitals. This is a young kid who had otoplasty at age of 4. At the time he came to, he was 9 years old. At age of 5, developed keloids on both ears. Again, treated with cryotherapy. Performing cryotherapy is a painful procedure. For this particular patient, when you're dealing with a kid, pain management is extremely important. For this kid, I coordinated with this plastic surgeon who would, under nitrous oxide sedation, inject him before he came to my office with liposomal bupivacaine that has a 3 days duration of activity. So he would go to plastic surgeon, he would actually induce complete anesthesia in both ears, then he would come to my office and would freeze everything. After a few rounds of cryo, we were able to debulk all of this. This is April 22. significant improvement and all around. He needed later on intralesional chemo. Then you deal with this 14-year-old, and I really don't know what to do with this kid. These are patients who need systemic treatment. This is biologically totally different condition. I wanted to share a lot of information with you about the survey that we did, and I'm going to basically show you one point of this, and that is, this is a large survey on over 2,000 patients, and we collected a ton of data, about 750 points of data from each patient. And we are going to focus on age of onset of the keloids. So if you basically look at patients at the age they present, the average age they present is about 30, 32. But when you ask these patients at what age did you develop your very first keloid, and this shifts with the mean and median of under 18. Under 18. So, and when you look at the patients who are on, and if you draw the line at 18, 60% of the patients develop the very first keloid under age of 18. This is a pediatric condition. That's why we're talking about this condition in the pediatric session, so that we know that this is a pediatric condition. This is not just an adult. I have a ton more data, but we don't have time to share, to review that. Thank you very much. I'll take any questions you may have, and I invite my next speaker.
First, one comment. You show beautiful results of cryo, and I think we take that in consider every time. But sometimes those big keloids on the pubic area are not to be treated, and it will not work completely. So, Michael, it will not always work. Sometimes you have to operate and do radiation, unfortunately. A question. Okay. Then for the next speaker. You were the next speaker? Okay. No. You're the next speaker. Yeah. Already. Okay.
So Dr. Deng is our next speaker. So let me load would you please load her presentation? Okay, just stay here then. So I heard your comment, Frank, about sometimes cryo doesn't work and we need to do surgery. The point is managing these patients from day one. The patient who is 13 years old now, how was his keloid managed from day one? That's important. The key is properly managing the keloid at the time of presentation by dermatologists, by pediatricians, by whoever who gets to see them first. As I showed you the data, this is a pediatric condition. Over 60% of these patients develop the very first keloid before they turn 18. And coring that keloid from the earlobe under general anesthesia for that 3-year-old, in my opinion, which is a very biased opinion, is wrong.
Is it true? I don't know what you think, but when people with these kind of keloids come to us, then they have been operated most of the time already. In this case, if a case develops out of an inflammatory reaction like a folliculitis, and you do cryotherapy on those, does it have a better result than when they have been operated before? Is there, in your opinion, a difference?
So my opinion is, I'll use this micro. My opinion is, we should not think like a reflex hammer. The moment you see keloid, the reflex is surgery. We need to break that reflex. We need to start thinking long term. It's not how I manage this case over the next 3 months. That's not the point. The point is This is a genetic condition of skin. It's going to be with this kid for the rest of his life. There is no ifs or buts about it. He has it here, 6 years from now, he's going to have it somewhere else. So we need to think long term. It's not that today I'm going to cut this out and you massage it and inject steroids and good. And if it didn't work, it's your fault that you didn't massage it properly. That is not the point. The point is think long term. What I am doing today for this patient, what is it going to do for this patient a month, a year, 10 years, 20 years down the road? And what's the impact of that? Would there be a negative impact in what I'm doing today? We need to have that principle and philosophy and strategy.